Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for doctors in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. Today we are bringing you a podcast where we're going to discuss burnout and imposter syndrome in junior doctors. My name is Chow Yen and I'm here with Dr. Sam King, and we're both medico-legal advisors for the Medical Protection Society. We're very lucky to have as our guest today, Dr. Ashwina Rao, who's an anaesthetist in Auckland. Ashwina has been an anaesthetist since 2003, and here's a little bit about Ashwina. She developed an interest in communication tools in 2015 after a conflict with an anaesthetic technician. She initially accredited as a process communication model trainer in 2018, which helped her to understand herself and others' motivations. And through this, she was introduced to the model of compassionate accountability, a useful tool for navigating difficult conversations. She has a diploma in positive psychology and well-being. Welcome, Sam and Ashwina.
Hi, Chayan.
Hi, Cher.
Hello. So today we're talking about something that almost every junior doctor experiences at some point. Burnout. And, well, I don't know if every junior doctor experiences imposter syndrome, but I think it's a very common experience, especially when you're first starting out and you're functioning under sustained pressure. And these are huge topics for us. And they're not just well-being issues. They affect our patients. They affect patient safety. They influence how decisions are made and how we communicate with each other and how we communicate with our patients. And I think what's really important to get across is that this is not just about you're not being resilient enough. That's not the problem. It's about how we all function under pressure and sustain pressure over long periods. Because burnout is an employment issue. It's a workplace stress that's chronic and that's poorly managed and not addressed. So, Sam, would you be able to tell us a bit about what burnout means?
Sure. Burnout is measured across 3 different domains. The first one is our emotional energy. So when we're burnt out, we experience emotional exhaustion. And that's not just a physical thing, but it's about an emotional tiredness, which reduces your capacity to cope with patients and colleagues. You know, we all have those days if you're really sleep deprived and you've been under pressure where some of us might, for example, get angry quickly, or some of us might flood into tears really quickly. That's because our emotional tank is relatively low. It's also measured across depersonalization, which most people, it's kind of like not sure what that means, but it's really about our attitude. We can develop a cynical attitude. And what that does is we push people away. I think it's a self-protective thing that when we're not coping, we don't want to cope with other people, so we tend to push them away, not just patients, but also our colleagues. And the third domain it's measured across is a sense of professional satisfaction. Most of us, particularly when early in your career, you're excited to get started as a doctor and looking forward to, what specialty you want to do and all those sorts of things. And when we lose that fire, when we lose that sense of satisfaction in what we do, and the love for what we do, that is often an indicator for burnout. And whilst it's not a psychiatric diagnosis, it is classified by the WHO, and it's known as a phenomenon related to occupation. So it's about your work. It's not about your private life. And I know that there are some of our colleagues, of course, who suffer from depression. But burnout is different in that it is specifically related to the workplace. And as you said, Cho, it can come on gradually, and that's why we don't notice it. And I think many of us have that attitude of being a little bit bulletproof and in denial. So it can creep up on us. And by the time you realise you're burning out, you're quite a long way down that slippery slope. And people often have, persistent exhaustion, irritability, loss of empathy is big, particularly for our patients. Difficulty concentrating, which means you're more likely to make a clinical error. And if you get that dread before going to work, at one stage in my work, I'm a GP, I remember that Sunday night feeling, that sinking, I've got to go to work tomorrow feeling. And it was awful, but it would happen every single week. So if you're getting that, that's not a good sign. And obviously there are lots of contributors to that these days. The way junior doctors work is really different now to when I graduated. And I think it's much harder. There's less continuity of care. Medicine's way more complex. There's lots of chopping and changing of consultants and teams and all of those sorts of things. And it can certainly create an environment that leads to burnout. I think that it's important that, as Chow-Yin said earlier, it's not a resilience problem. I'm sure all of us are resilient, because if you weren't resilient, you wouldn't get through med school for a start. The fact is that all of us have a breaking point, don't we? We all get to that point where we cannot cope anymore.
And it's not always just about work. It's what else you've got happening.
That's exactly right.
In your life. And there are lots and lots of statistics out there about burnout, and there are surveys that show that around 30 to 60% of trainees report some burnout symptoms, depending on, of course, how it's measured. So, Ashwina, what suggestions would you make if you're approached by a trainee who appears to be struggling with their work?
I think, firstly, that this is a really important topic, and bringing this kind of thing out into the open really will help people to normalise the feelings that they're experiencing. You're right that people go through the idea of medical school with the idea of where they're going to end up, and there can often be a gap between what they're feeling and what they want to feel. And that's where the struggle is. For me, approaching these situations or conversations with openness and curiosity without judgment are really the keys. So firstly, start with what I've noticed, and keep those sorts of observations quite specific. Might be that you can say, I've noticed that you seem a bit withdrawn recently, or you don't seem quite yourself. Is there something going on for you that you want to talk about? I think that that's much less threatening than using the label of being burnt out, because there are negative connotations associated with that. And also the idea that it's okay to feel tired, it's okay to feel exhausted, but that doesn't mean that you are not competent. It's having a sort of idea of duality, of having both. And I think that often, as you said before, people earlier in their careers are juggling with lots of different things. They could be juggling with family life, with expectations, with the idea that they're competent. They could be juggling the idea of being fatigued, but also having to be on their A game all the time. And so it's helpful to normalise that being depleted doesn't mean that you're not capable. I think the idea of emotional exhaustion might be a little bit alien to many people, because people do often associate being tired with something physical. And it can be helpful for people to try to understand, where is that emotional exhaustion coming from and how can they address that? Because in medicine, it can be very demanding as a junior, especially, and finding a pattern that works, for example, regular exercise or regular connections with friends, can actually help to recharge a battery that's depleted. So I think the third thing I would suggest is to ask practical questions, not just emotional ones. So which parts of the job are draining you most? Or are there certain interactions you're finding more difficult? Or do you find it's hard to recover between the shifts? So the sense of openness to just empathise with the situation, validate the normality of those feelings, and then to ask them to internally reflect, are there any specific things that are contributing to that? Are a useful place to start.
Yeah, I think that's really helpful, that the differentiation between fatigue versus emotional exhaustion, because they're really different things. people talk about fatigue being, whenever I think of fatigue, I think, it's because I haven't slept very well for 9 years. But that's because I have little kids.
Only goes on for another 20, it's fine.
Yeah. But I think that's really different to emotional exhaustion, because emotional exhaustion can be about so many other different aspects of your life, and it's not necessarily just about work. But of course, when you're at work, all of that comes into play, because we're not just unidimensional people. I know that, Sam, you've had a case where a member was burnt out.
Yeah. It was around that time that I was running workshops on burnout. It was quite interesting. And, this was a GP with a young family. She had a lot of social stresses going on with the death of a close family member. She, relationship breakup, all of those things. And she's a conscientious doctor, so she was working very hard. And one day I think she was on leave, and one of her colleagues took over her inbox and realised the inbox was overflowing.
Okay.
In primary care, what happens is that we do our own inbox, and so no one knows how big our inbox is until we go away, and that's what happened. And that's how a lot of these things get picked up, to be honest. And so don't go away on leave as if you've got an overflowing inbox is probably the corollary here. But so they picked that up, and then they realised referrals were behind and all of those sorts of things, and they ended up reporting her to the medical council. And she went to a workshop on burnout, and she suddenly realised, oh my gosh, I tick every single box. All of the things we talked about on those 3 domains, she went through and just suddenly realised. And I think that's the difficulty for us as clinicians, is we don't realise until something slams us in the face, and we're confronted with it, and then we get to realise these things. And that, for her, she was quite a long way down that slide. And I take my hat off to her. She worked really, really hard to get herself back. She changed a lot of things in her life. She sold her practice. She moved into a slightly different specialty. And she really made a massive effort to get back on track. And she did. Within about 2-3 years, she was off and away, and she's, loving life again. And I think it's worthwhile to think, is it emotional exhaustion, not just fatigue? What else is going on? And because if we're not aware of it, if we don't pick up those signs early, then it can take a lot longer to recover. Whereas I think if we can think, actually, I need to make some changes now, it will stop you sliding into, into that hole.
Yeah. No, I think that's, it's such an interesting example of how it impacts everyone differently. So she was still a great GP. Her patients still loved seeing her. But that aspect of her practice that she wasn't managing was her inbox. And I think for some clinicians, what manifests is through communication. So, when I was working in the ED, I always remember the terrifying registrars that would ask me so many questions and be really upset with me if I didn't know the answers. And actually, when I saw them outside of work, they were really friendly and open and sociable. So I think that in some cases it does manifest when you're at work with communicating in an abrupt manner, or you feel like you can't manage. So what do you think about that, Ashwina? Do you see that in the way people communicate when they're feeling stressed or burnt out?
Yeah, I think that's a really good question. I think burnout can often first manifest itself in the way that people communicate. If you can observe yourself and the way that you communicate and reflect on how that changes, that would be very powerful. But for most people, it may be observed by other people. For junior doctors especially, they're grappling with having very little experience and feeling that they don't have as much competence compared to their peers. Peers meaning seniors. And therefore they have to exert quite a lot of emotional energy to have real-time conversations with other people. If you think about patients in the hospital, patients usually are under stress. And the way that they communicate is also coming from a place of not feeling okay. And the natural part of communication is that the interaction tends to mirror itself.
Yeah.
So if one person's stressed, the other person absorbs it and it reflects in their communication. That can be subconscious. You may not notice that that's happening. And the real-time part of that is it takes a lot of energy to be able to do that, especially when you're learning the job at the same time. And that's where there's a big difference in the way that juniors communicate under stress compared to senior clinicians.
Yes.
So what they may find is that they do become more transactional, thinking of patients as tasks. They may not have much emotional bandwidth to explore conflicts.
Yeah.
So they may withdraw from those. They may not remember to do things in the handovers. And those things can manifest as problems.
Yeah. And I think we were going to briefly touch on, or we talk about imposter syndrome a little bit here. And I think there is a degree of that feeling where you want to appear confident. You know, you might be a first-year registrar, but you were a house surgeon last year, and you want to be confident and you want people to have faith in you and your decisions. So you might project yourself in a way that's not necessarily how you're feeling. So the other person might perceive that you're coming across as arrogant, or why haven't you done that before referring to me? Why haven't you done, a complete neurological exam and ordered all the imaging that I would want before you refer to me? And that can come across as perhaps a little bit belittling on the receiving end. But for the person that is communicating in that way, they're feeling stressed and they want to project confidence.
There's a lot of pressure in medicine to get it right.
Yes.
When you're in a hospital system, particularly as a junior doctor, probably as a senior doctor as well, but as a junior doctor, you know what it's like. You get questioned on the ward round, in front of all your, the nurses, the patients, all the doctors, and it's like, I have to have an answer. So it is a very difficult position to be in, I think, depending on what the SMO is like or the person questioning you is like. And so I can understand why many clinicians have imposter syndrome, and I can understand why they struggle emotionally with being able to deal with people. I don't know what the answer to that is, but I just want to acknowledge that it's not easy.
I think actually looping back to something that you've both just said, Cheyenne, you said about the perception of the person you're talking to. We can't control the way that other people communicate. And so being on the receiving end of someone who is appearing to either be short or aggressive or probing in the way that they're questioning us, we can't control that. We can only control how we respond. And it can take some time and some practice. But the ideal state, especially for junior doctors, is understanding that the way that somebody else communicates is a reflection of them rather than you.
Yes, I think that's really important.
Really, really important. And that can be very valuable to try and take stock in that moment before you react or respond. And then what you were saying, Sam, then for the junior doctor on the ward round where they're being asked questions, there is this idea of a dirty question or a clean question. So a clean question would be one that's coming from a place of curiosity, asking an open question, what do you think about this? Rather than, why don't you know that? And again, how you respond to that can take some time and practice to take stock and think, okay, the way that the question is being asked is inviting me to feel that I am a problem. Can I reframe that in my mind to answer the question in a way that satisfies curiosity rather than looking for what I don't know?
Oh, I see.
That's actually a very good way to look at it.
Yeah.
A really good way to look at it. I mean, nobody expects a house officer to know everything. It's impossible.
No, we don't know.
No, nobody
Half the
knows
things out there.
everything,
Yeah.
right? Yeah. And so it is about how we view it, how we frame it to ourselves. I think that's a really good point.
Yeah, I really like that. That's not about you, because you can't control how they are communicating with you. And so I know that burnout affects us in the ways we've talked about already in our jobs. So how does imposter syndrome sometimes manifest in a negative way? I know that sometimes you can think, oh, I really think I should know this, and so maybe I'll just sit on it a little bit longer before I call my consultant. Does it manifest like that sometimes? Or is it more that you have feelings of self-doubt all the time? And I think both of those descriptions do capture how you can feel when you've got imposter syndrome, because it's that constellation of feelings that you don't want to feel inadequate, you want to feel competent, and you want to project confidence that might lead us to sometimes maybe not calling when we should, or trying to know the answer when we don't really, or not asking or not asking a question when you're not sure.
I think that's a really good point. I think the way that communication changes in imposter syndrome is very slightly different, because, as you said, that the underlying driver for that is self-doubt and fear of being exposed as being inadequate. It doesn't necessarily correlate with competence. So someone who is very competent may have imposter syndrome. So the gap there is between how they feel about themselves and how they actually are. People with imposter syndrome may tend to over-apologize. So use lots of over-qualifiers and talk more than someone who has burnout, who tends to withdraw and speak less. They may be less likely to escalate concerns, because that perception is that if they ask for help or advice, then they're exposing themselves as being incompetent, when in actual fact that would be the safest thing to do. So they may need more reassurance.
Yeah.
I guess the hard part for more senior doctors is recognising that imposter syndrome might be at play. Because how do you recognise it in somebody else? It can be difficult, I think.
Yeah. And for us, we might just think that, they don't know what they don't know, and then it becomes an unfair criticism of what's actually at play.
I think in all levels of experience in medicine, there is an element of we don't know what we don't know.
Yeah.
Because medicine is evolving and changing.
Yeah.
I think that one of the problems earlier on in your career is that you really have no idea at the time frames in which there are things that you should know and don't know. Of course, there are things that, of course, you should know. But we don't, unless you talk about it within your specialty, with your seniors, it can be very difficult to navigate. The whole thing is in the dark, effectively. And bringing out conversations like this into the open with your peers, with your seniors, are the things that will help to navigate that. We can't take away the struggle, but we can ease the suffering by employing tools which can help.
Do you think that in the teams, like, for example, out there in the hospitals today, that the environment is such where you can actually bring it out into the open and talk about it? Would you say that, I mean, I haven't worked in a hospital for a very long time, obviously, but, would you say that SMOs are open to that kind of conversation?
So I think that's a great question. Openness in the culture of medicine is one of my greatest passions. I'll just speak from my own experience in anaesthesia. I have worked at North Shore for 10 years almost. And we have a really well-established long history of doing a really valuable M&M. We do it 3 times on alternate weeks. It's led by a group of consultants. We regularly talk about things that didn't go the way we planned, things that happened out of our control. And the cases are discussed in a very open way. And they're responded to in a very open, calm, respectful way. No one is probing or questioning. People are asking questions out of curiosity. The goal is just to learn and to improve, to change systems where they could have supported a better outcome or different outcome. I think I'm very lucky, both in our specialty, but certainly in our hospital, because I know that that isn't the case elsewhere. And so the culture of openness really depends on the group of people.
Yeah, absolutely.
And as a junior doctor, I would have thought you'd feel a little you probably are quite powerless to influence that culture particularly. So in that situation, how would a junior doctor, where would you go? I'm struggling, I'm feeling terrible, I'm they probably don't know they've got imposter syndrome. They probably just think I am really incompetent. What would you advise? Where do they go? Who do they go to?
Well, if you're on a training scheme, there's always a supervisor of training you can talk to. All hospitals have EAP where you can access.
I mean, they can go to their GP, of course, but I'm just thinking about I'm struggling in the hospital. I feel like I'm incompetent.
Yeah. So there's a house surgeon supervisor who's usually a consultant. Often in some specialties you get assigned mentors as well. I don't know if that's always that effective if you're just given someone that you don't know and you're expected to make contact. But if you can identify a buddy or someone you trust, I think that's always really useful.
So there are people
definitely
in the
there are
hospital
assigned
that you can go to. That's really good to know.
Yeah.
And we have an established mentoring program in our department.
Yes.
I think that having medical students or having anybody with us, really, we would hope that we could create that feeling that if you're struggling with anything, then talk to us. And having those open conversations wider than what specialty do you want to go into?
That's right.
Or, can you put the cannula in?
Yeah.
Are really nice opportunities to be able to open out those kind of issues.
Yeah, I think when we move on to talk about how do you address these issues, I think that's a really important one that you've got to, it's hard, isn't it? Because you've got to make the step to feeling comfortable or feeling able to talk about it. But there are other ways of addressing burnout, and I think some of them, certainly conversation's really important. Reducing isolation. Studies show that students who maintain friendships in the midst of stress to be better in exams and in your time and your training compared with those who isolate themselves. And prioritising recovery, sleep, time away from work, take the annual leave, do something that you like to do. And then if you can find, people talk about the 20%, 80%. Are you able to talk to us about that, Sam?
Yeah, so the 80-20 rule is just an old saying that came from years gone by, where basically to achieve, for example, 80% in an exam requires about 20%, say, of time. But if you want the extra 20%, it requires another 80% of work.
Oh, yeah.
So it's really hard to get an A+ versus a B+, right? And so there are lots of things that we do where 80% is good enough. And so it's about remembering you don't need perfection in everything you do. Of course, you need to get some things completely right. I want my wound fully sutured, not just 80%. But there are lots of things 80% is fine. And so think about what that is. What are you wasting your energy on to reach perfection that you don't actually need to? I think also there's been some really good studies. There's a fantastic book written by Lauren Schwartz, The Powerful Engagement. And in it, they talk about the studies they did with top athletes. And French Open is on at the moment. So if you look at the top athletes, the ones who consistently are very highly ranked, they tend to have really good recovery moments within a game. So for example, you'll find they have a ritual and a routine. They don't have to think about it. This is what they do every game, and that gives them time to recover briefly, even for a minute, and then they can pop back up into performance mode. So in the hospital system, when can you take, a couple of minutes out? When you go to the bathroom, can you also take a moment at that point to, I don't know what you want to do, look out the window, have a drink, go chat to a friend, whatever that happens to be. But every 60 to 90 minutes, you should be having at least a couple of minutes off just to refresh. And that's often enough to keep you going through the day rather than hammering all day. And I know that, for a lot of us, we've got urgent tasks.
Yeah.
But you can actually perform better, much better, if you take those small breaks.
Yeah.
Yeah, so I would think about the 80-20 thing and about how you take breaks. And I know it's hard as a junior doctor, but we do know as well that if you can spend 20% of your time doing something you actually love at work, that will make a difference.
Yeah.
I mean, as a junior doctor, that's probably difficult. I don't know if that's even possible as a registrar to do that. But let's just say, you prefer one procedure over another. Can you spend more time doing that procedure? Or whatever that happens to be for you? That 20% is enough to get you through.
Yeah.
Because it'll just fill you.
Yeah. I think I remember one of my colleagues, he's very sociable but clearly introverted. And a few times a day I'd be like, oh, where's, so-and-so? And he'd always be out by the lake looking at the ducks, just taking a moment by himself because it's all so many people around us all the time. And then he'd come back and he'd be back to his normal, cheerful self. So I think this concept of self-awareness and knowing what you need in your day to recharge. The coffee break, the group coffee after your busy ward round might not be recharging for those of us who like solitude. So, go have a look at the ducks.
I love these two parts that you've just brought up. I always ask the medical students and the junior doctors prior to specialisation, where do you feel most energised? And this is something that I learned doing process communication model. So if we think of different quadrants of being alone, being with one or two people, being in a group, or being group to group, we can very quickly put different specialties in the groups. Because ideally you spend the majority of your day in an environment where you feel recharged, similar to going to a party. And anaesthesia, that's one of the reasons I chose anaesthesia. I'm with one patient at a time, and I spend time just understanding that patient. And when that patient's done, I move on to the next one. I don't get overwhelmed by multiple things happening at the same time. And so because I spend the majority of my day doing that in that environment, when I go home, which is arguably at least, if not more important for me, then I have energy to spend with my family. And that interface there can be the reflection, as you say. You may not show it in your work. You may be very focused and structured and organised in your work, but have no energy by the time you get home. And that's where your fuse starts to show that it's a bit short. And so it's a good reflection to have an idea where are you getting your energy and where is your energy being depleted.
I think that's a really good point in terms of where you think you want to specialise. I mean, you might really enjoy the surgical learning, thinking about operating and the practical skills that you would have to learn as a surgeon. But I think you do still need to think about the environment, don't you? And what the training will be like and whether your personality is suited to that particular specialty, whatever you choose, because you're going to be doing it for a very long time. And there's nothing more exhausting than doing something that you don't really love.
Yeah, absolutely. And, talking about how you can address those feelings of stress or burnout, I think people talk about perfectionism a lot and that how trying to be perfect is really stressful. And so if you can let go of one thing, that means that you may not be perfect, but just leave the dishes in the sink tonight. They don't need to be washed.
They do need to be washed.
I'm a big advocate for that. At least once a week, leave the dishes.
That's
the dishes.
right.
But yeah, and I think also in the workplace though, what is it that you don't have to rush to do? What is it that you can leave?
Yeah.
For later, what can you do that 80% is good enough?
Yeah.
And perfectionism I think is very common in our sector, and if you can work that out, perfectionism never works for anybody.
Yeah.
And it's certainly a factor, I think, to leading to burnout.
Yeah. Well, I think we've covered a lot today. We've gone through symptoms of burnout and some approaches to how we can address it. Do either of you have any other comments for our listeners?
I think for me, I would say, don't let shame stop you from speaking up that you need help. We all need help from time to time. It doesn't mean we're weak. It just means we're human.
Yeah.
And I think you'll be pleasantly surprised to find out that a lot of your colleagues feel exactly the same. It just takes courage to speak up.
Yeah.
And you want to just speak up to the right people. Go and see your GP if you need to.
I think that's really important.
Take up the EAP if you need to.
Yeah.
Those things are there to help you. Those people are there to help you. So don't let shame stop you from getting what you need.
And you're entitled to your privacy.
Absolutely.
If you would like it. Yeah.
I think that's great points there, Sam. It's okay if you don't feel okay.
Yeah.
Most of us don't feel okay all the time, and that's all right. I think the important thing is that we treat ourselves with kindness and have self-compassion, and with the right supports, we can all work and flourish in medicine. And in those circumstances, the patients get the safest and best care.
Absolutely. Absolutely. So I hope you found this helpful. Thank you, Sam and Ashwina, for joining us today. And thank you to our listeners. If you're concerned that you're suffering from burnout, or if you feel you're not coping at work, like we've already mentioned, please seek help from your GP. And MPS have a counselling service which members can access by calling 0800 22 55 677. If you enjoy our podcasts, please subscribe and like them. If you have any suggestions for other podcasts or helpful feedback, please email us at nzpodcasts@medicalprotection.org.